بسم الله الرحمن الرحيم. برحب بحضراتكم في مراجعة موديول البيدياتريك. وأنا عارف إن هو موديول صعب ومش لطيف قوي، لكن ما باليد حيل. هنعمل نفس اللي احنا عملناه في المرات اللي فاتت، وهنعرض على حضراتكم شوية حالات وننتظر الإجابات بتاعتكم عليها بإذن الله تعالى. And the first case is a female child, 6 years old, and she is complaining of fever and cough. This is the chest X-ray, and there are some choices: round pneumonia, bogdalic hernia, diaphragmatic eventuation, pulmonary sequestration, pulmonary AVM, posterior mediastinal neurogenic tumor. Around pneumonia, الإجابة, and then this is right. The correct answer is round pneumonia, and they know that round pneumonia is may simulate a pulmonary nodule or pulmonary mass. Actually, the air bronchogram is not that clear in this type of pneumonias, and it is diagnosed by the clinical data. And if you know that the patient is complaining of fever, cough, and sputum, and he has a rounded lesion inside the chest, especially if he is a pediatric patient, then you know that you are dealing with round pneumonia, which is more common in the pediatric population compared to adults. This is the second case, and the patient had dyspnea on exertion, wheezes, reduced the ability to exercise, cough, and left-sided chest pain. And this is a suggestion for the first question. AVM is not right. It was a round pneumonia. Then we are now with the second question about this chest X-ray. Do you feel that is a normal chest X-ray, for example? Okay. And for the first while, you can feel that this chest X-ray is normal, but if you look carefully, and you can see that the pulmonary vasculature on the left side is much more reduced compared to those on the right side, and you got some hypertranslucency on the left side. And if you see the CT scan, and you can appreciate this, the pulmonary vessels are scanty on the left side. The left lung looks a little bit smaller compared to the right lung, and these are the criteria of McLeod syndrome, um, or and this syndrome is well known, and it may be secondary to some attacks of bronchiolitis in the pediatric age group. Then you got diminished pulmonary vascularity and also hypertranslucency. The next case is chest CT scan showing this is actually a coronal, a bron position, in order to realize that these lesions are not dependent opacitors, but they are real opacities. They persist in the prone position. Then usual interstitial pneumonia, this is right, and this is usual interstitial pneumonia or idiopathic pulmonary fibrosis, because you got too many strandy opacities in the lung, and you got traction bronchiectasis, and very important, you see the honeycombing, and this is usual interstitial pneumonia. This is a pediatric abdomen, and you got some translucency in the abdomen. Yes, and this is massive pneumoperitoneum. This is right. You see that air is surrounding all organs in the abdomen, and you got the accumulation or crowding of the abdominal organs in the midline, and this is diagnostic of pneumoperitoneum. The next case is chest X-ray and ultrasound for this superior mediastinal shadow. Yes, very good. This is normal thymus. And you remember that I have said that a child below the age of 1 year, the thymus looks like this, while after 1 year, it looks like the sale sign. Then it is expected, very expected in the neonatal chest, and you got a broad superior mediastinum because of the normal thymic shadow. And next case is a CT scan of a patient obtained during expiration and during inspiration. Mosaic perfusion means air trapping. If there is patchy areas in the lung of ground glass alternating with hyperinflated areas, and this is known as the mosaic appearance, and it means that there is air trap, and the possibility of a small airway disease may be considered. But if you look carefully for the trachea, and then you see during expiration, the trachea is collapsed and also the main bronchi. While after inspiration, the trachea is rounded and the bronchi are distended, and this is diagnostic of tracheobronchomalacia. And this diagnosis cannot be made unless you have these two images, and you can predict the diagnosis. If you see the trachea like this, the trachea should be rounded. And if the scan is obtained during expiration, then you can see the trachea is collapsed and also the main stem bronchi, and you can easily diagnose tracheobronchomalacia. The next case is a 13 years old boy.
طب وكده اقول لك حاجه اللي بقول لك ايه تطلع بتطلع عرض الدوري تطلع
13 years old boy, and the chest X-ray showed diffuse lung disease. The CT scan showed this appearance, and it is one of the characteristic. Yes, this is alveolar proteinosis because of the crazy paving appearance. If you look carefully here and you see the crazy paving, which is one of the pathognomonic features of this particular disease. Next case, you see a chest X-ray with diffuse lung disease as well, Then in the CT scan, you got patchy alveolar opacities and some areas of air trapping. But it's very important to know the history of this patient. He is a male child with 1 week history of cough and sputum. The patient had been taking 20 cc Lorenzo oil twice daily for the last 3 months. And this is the clue for the diagnosis of lipoid pneumonia. The answer is right. You cannot diagnose lipoid pneumonia without the history. It looks like any type of pneumonias, like viral, bacterial, any type of pneumonias. But if you got the history of these oil products, then you predict that the patient had lipoid pneumonia. The next case is a CT scan of also a diffuse lung disease of a child, and you can see the distribution of the lesions is very pathognomonic for a particular lesion. No, this is not miliary TB. Yes, and this is right. This is sarcoidosis. There are only two lesions in the diffuse lung disease which can produce opacities of perilymphatic distribution. And this is very important. The most common is sarcoid, and the second common is lymphangitis carcinomatosa. You cannot diagnose lymphangitis carcinomatosa unless you know that the patient had a primary malignancy. But if you see this very, very characteristic distribution, very lymphatic, and you got thickening of the interstitial spaces and nodular lesions arranged along the pleural surfaces, like the fissure, which is the best one to predict these nodules, and also along the pleural margin. This is very important. Then if you look carefully to the hilum and you got big hilar shadow on the left and other hilar shadow on the right, then you are dealing with sarcoid. Next is neonate, and he is examined to diagnose a certain anomaly here. Imperforate anus, yes, and this is imperforate anus. This is known as invertogram. You put the child in the inverted position for some time in order to allow air to accumulate in the most distal part of the colon. And you fix a metallic marker at the suspected site of the anal orifice. Then you see the distance between air and the marker. If the distance is short, and this is low atresia, if the distance is long, like this one, and this is imperforate anus or high atresia. CT chest of this child, and you got two lesions in the lung. Yes, and these are hydatid cysts, of course, because they are filled with water. They have thin margin. They do not enhance with contrast, and this is diagnostic of hydatid cysts. Next case is a chest CT, and it shows also diffuse lung disease. And here you got ground glass opacities, you got some traction bronchiectasis, and there is no evident honeycombing. The answer is right. Non-specific interstitial pneumonia. Very good. And this is the diseases that can affect adults. Some of the diffuse lung diseases that can affect adults can also seen in the pediatric age. Next case is a CT scan axial and coronal reconstructed images after contrast injection. Yes, and this is emphysema. Very good. There is an encysted collection in the pleural cavity with enhancing margin, and there is evident collapse or compression collapse of the right lower lobe, diagnostic of extrapulmonary collection, and there should be in the dura diagnostic of emphysema. Next is this child, 9 years old, obtaining the CT scan of the chest during inspiration and expiration and is clinically diagnosed query asthma, bronchial asthma. Foreign body inhalation on which side? Both sides? Left side? No. Actually, in cases of foreign body inhalation during inspiration, you got almost normal lungs, but during expiration, you got a normal lung and a hyperinflated lung. But in this case, you can see that both lung fields are showing the mosaic appearance with areas of ground glass and areas of air trap. The very dark areas represents the areas of air trap. And this is actually diagnostic of small airway disease, and the patient is, is suspected clinically to have bronchial asthma, which is the most common type of small airway disease in the pediatric age group. This chest X-ray of a neonate very distressed, intubated, and is in the intensive care unit. Yes, respiratory distress syndrome, and this is known as in the neonatal period as hyaline membrane disease, and then this disease is commonly seen in the premature infants, and the original the causing factor is the deficiency of surfactant, which enables the alveoli to expand and deflate. And then you got this very characteristic appearance of white chest with some air bronchogram inside, diagnostic of respiratory distress syndrome or hyaline membrane disease. This is usually seen in preterm infants, and the underlying cause is the deficiency of surfactant in the lung. Previously known as hyaline membrane disease, and this name is more accurate considering the histologic diagnosis of the affected lung. 7% of cases are seen in infants and at the age of 37 weeks gestation, delivered by cesarean section. Also in infants of diabetic mothers, the surfactant reduce the surface tension of the alveoli, then its deficiency will result in inability of the alveoli to expand. The chest X-ray will show poorly inflated lung with diffuse ground glass appearance, some reticulonodular opacities, air bronchogram, The disease may worsen in the first 2 to 3 days and then stabilize in the next 2 to 3 days. And the patient is usually ventilated and injected with surfactant to treat this condition. And this is the surfactant, which is a mixture of phospholipids and the proteins, and this will help the alveoli to expand. And the tissue, the alveoli sticks together without surfactant, causing alveolar collapse. Then the patient will be ventilated and injected also with surfactant. Next case is barium meal of a neonate presenting by projectile vomiting. Yes, and this is a classic appearance of mid-gut volvulus, and you see the corkscrew appearance of the duodenal and the jejunal loops, which is very characteristic for mid-gut volvulus. Next case is a chest X-ray of a neonate also with marked respiratory distress. Yes, and this is tension pneumothorax, very good. You got marked accumulation of air in the right hemithorax with compression of the underlying lung, marked depression of the diaphragm, and the shift of the mediastinum to the opposite side. All these criteria are helpful to diagnose tension pneumothorax. And the next case is a chest X-ray showing this appearance in the left lung. Yes, diaphragmatic hernia. The answer is right. You got intestinal loops filled with air, and these loops, the air in the loops is continuous with the air in the abdomen. Diagnostic of congenital diaphragmatic hernia, which is much more common compared to the cystic adenomatoid malformation of the lung, where you can see also multiple cysts in one of the hemithoraces, but the air in these cysts is not continuous with air in the abdomen. This is a chest X-ray of a unit also in the intensive care, and you can see a similar appearance to the hyaline membrane disease, which is true, but the question here is about one of the tubes that are not in its accurate location. Yes, and this is malposition of the endotracheal tube. This is the edge of the endotracheal tube. It should be above the carina by 5 centimeters. But this edge of the endotracheal tube is almost at the level of the carina, which is considered a wrong position because this endotracheal tube moves with neck flexion and extension. And if it moves down, it will go into the right bronchus, then the left lung will collapse. And this is very important to be considered. Next case, a chest X-ray of a child showing this lesion in the right lung. Neuroblastoma, I consider this is right because if you see a mass in the chest of a child, then you consider first possibility neuroblastoma. Then if you are asked about the differential diagnosis, then you may say that this may represent hydatid cyst, for example, or a big metastatic deposit, or if the patient had a positive history of infection, then you consider it some kind of round pneumonia. But this film is actually presented here in order to look for these calcific shadows in the lesion, and these calcific shadows, let us say, may look like teeth, for example, but this would be a very difficult case if it is presented in the exam. But whenever you are confronted by a mass in the pediatric chest, think first of neuroblastoma. And you know that neuroblastoma contains calcium, but calcium is not that evident in the plain film. It is evident in the CT scan. Then take a moment to realize or to look carefully about these calcifications. If they look like the teeth derivatives, then you may predict the possibility of mediastinal teratoma. This is a female adolescent, 18 years old, and the CT scan of her chest showed this appearance. She had the chest X-ray, and the chest X-ray showed widening of the mediastinum, and then they have to have the CT scan to look for the cause of widening. Then these are the suggested diagnoses: mediastinal lipoma, mediastinal lipomatosis, mediastinal liposarcoma. One is asking about the previous case. What about the cardiac silhouette? And actually, the cardiac shadow is totally compressed and displaced to the opposite side. It is not in its actual location. Then if the heart is here, then you may have the right to say that this should be an anteriorly located lesion, because it's a silhouette with the cardiac shadow. Then you may think of this pathology, which is mediastinal teratoma, because the neuroblastoma and all the neurogenic tumors are located posteriorly. Yes, this is a good observation. And in this case, lipomatosis is actually mediastinal lipoma is a mass of fat within one compartment of the mediastinum. Mediastinal lipomatosis, meaning that a big amount of fat surrounding the vessels in the mediastinum. Liposarcoma, of course, fat and other tissues, plus calcium sometimes. Then this case actually has been proved to be a lipoma of the thymus. This is actually the anatomic site of the thymus. Lipoma is a very soft mass, and it can spread between the vessels, as you can see. But if you put a differential diagnosis for this, like mediastinal lipoma, a lipoma of the thymus, it will not be wrong. Then you should know that thymolipoma, or lipoma of the thymus, is one of the very big lesions. It can fill the whole mediastinum and reaches the diaphragm. As you can see here, there are a lot of vessels within this fat-containing mass, which is huge enough to fill most of the right hemithorax and part of the left hemithorax. The thymolipoma represents about 5% of thymic tumors, and the mean age of presentation is around 20 years, and it is containing fat with no with non-invasive characters, and actually it is suppressed on MR fat suppressed sequences. The next case is an MRI of the brain, T1 and T2 of a child clinically suspected to have hydrocephalus. Yes, normal variant. Well, yeah, it is a normal variant, and this is known as infantile benign enlargement of the subarachnoid space in infancy. Some of the infants may have large head, and they are diagnosed as hydrocephalus. Then, when they have a CT scan or MRI, the report may say that this is atrophy, and this is wrong, because there is a well-known entity in the infants who present by large head, known as benign enlargement of the subarachnoid space in infancy. And this is very characteristic in the frontoparietal area, especially or almost in patients presenting with large head diagnosed clinically to have hydrocephalus. This is a self-limiting lesion, and it resolves spontaneously. Um, this male infant, 3 months old, presented by lethargy, and is not well fed. Yes, and this is hypoxic ischemic encephalopathy. The white cerebellum sign, or the reversal sign, you got extensive hypodensity of the brain tissue, sparing the basal ganglia, the brain stem, and the cerebellum, and this is known as hypoxic ischemic encephalopathy, and a lot of reasons can cause this, and this is the serious disease where you got ischemic changes of most of the brain tissue. This is known as global ischemia. The next case is a male, 3 years old, presented by headache after severe attack of gastroenteritis. The white cerebellum, yes, and is due to the black cerebral hemispheres, of course. What do you think about this case? Yes, and this is internal cerebral veins thrombosis. You know that the quadrigeminal cistern contains 4 structures: 2 internal cerebral veins, the pineal body, and the vein of Galen. Whenever the internal cerebral veins are thrombosed, and you got ischemic changes in the thalami, very characteristic appearance, and they are of low signal in the T1, high signal in the T2, and flare with diffusion restriction. If you have the MR venogram, then you know that the internal or the deep venous system of the brain is the 2 internal cerebral veins, the vein of Galen, and the straight sinus. And you see that all of these are thrombosed. But If you have this symmetrical appearance and you don't have this history, of course, is due to dehydration. Severe gastroenteritis resulted in dehydration, and dehydration is one of the etiologies of deep vein thrombosis or venous thrombosis in general. But if you lack the history, sometimes and not always, you can see the blood clots in the internal cerebral veins, not seen in this particular case. And soon I will present a lecture or a series of lectures about the differential diagnosis of many of the pathologies, and I will include the pathology of the basal ganglia and the thalami in this group of lectures, inshallah. Then this is the characteristic venous infarction secondary to internal cerebral vein thrombosis. 10 years old male with spastic paraplegia, and there are some choices. Um, B, yes, and the answer is B. Periventricular leukomalacia. You got a scanty appearance of the white matter in the occipital lobes compared to the frontal lobe. You got undulation of the ventricular wall, and you got abnormal signal within the white matter. This is diagnostic of periventricular leukomalacia. Male child, 2 years old, with the characteristic distribution of the lesions. And you see in this FLAIR images, you got bright signal in this particular part of the brain, and you got some bright signal also here. And may be affection of the basal ganglia, but in this case, no. Yes, and this is Leigh disease. A very good diagnosis. This is Leigh's disease, and Leigh's disease is a mitochondrial abnormality disease, presents by muscle weakness, dystonia, vision loss, ataxia, tachypnea, and seizures. Then the most characteristic appearances in this Leigh's disease are the presence of high signal in T2 and the flare, low signal in the T1 in these characteristic locations. So number one, the putamen and the globus pallidus of the lentiform nuclei, the caudate nucleus and the thalamus, the periaqueductal gray matter and the brainstem. Periaqueductal in this region around the tectum of the midbrain. A white matter affection is atypical, and this will show, of course, the MRS of these lesions will show very high lactate level. And this is a male child, 5 years old, with acute onset of headache, vomiting, and ataxia. Yes, and this is epidermoid cyst, characteristic location, characteristic appearance. Right cerebellopontine angle cystic lesion, hypodense in the CT with no enhancement, hyperdense in the high signal in T2, and marked diffusion restriction, diagnostic of epidermoid cyst. Yes, this is a classic appearance of hydatid cyst in the brain, very smooth outline, fluid signal in all bulb sequences, and no enhancement, no surrounding perifocal edema. Next case. it's not herpes. It's one form of encephalitis, but it's not herpes. And herpes encephalitis, and you got diffusion restriction, and here there is no diffusion. This is the EDC. It showed no diffusion restriction, but you got abnormal signal in the hippocampus bilaterally, and the T2 and in the FLAIR images. And then if you inject contrast, it will not enhance. And this is, yes, very good characteristic of limbic encephalitis, which is an autoimmune disease resulting in bilateral symmetric involvement of the region of the hippocampus and the amygdaloid nucleus, and it does not show diffusion restriction and also does not show post contrast enhancement, while the herpes encephalitis will show diffusion restriction. This is a reaction to tumors outside the CNS, and is considered one of the paraneoplastic syndromes. It presents by memory loss, seizures, and psychologic features. The most common neoplasms that can be associated with limbic encephalitis are small cell lung cancer, testicular tumors, breast cancer, Hodgkin disease, and thymoma. In about 60% of patients, the cancer is not present at the presentation of limbic encephalitis. CT scan of the chest showing big mass. Yes, and this is teratoma or teratodermoid cyst. It shows the all criteria of germ cell tumor, big mass of soft tissue density, internal patchy areas of calcification, as well as internal areas of fat hypodensity. And this is MRI of the brain at axial T2, axial T1 post contrast, and axial diffusion weighted images. Now, the pineal cyst is a midline lesion, and the only cyst which produce diffusion restriction is the epidermoid cyst. And this is not the site of colloid. Colloid cyst is located here at the foramina of Monroe, but this cyst is located in the quadrigeminal cistern, is of low signal in the T1, high signal in the T2, does not enhance, shows diffusion restriction, diagnostic of epidermoid cyst. Next case. Um, And this is actually not a child, but she had a disease which is uh, usually presents in the pediatric age. She presented by transient ischemic attacks, and these are the MRI, brain MRI. Yes, and the answer is right. This is gray matter heterotopia. You got multiple subependymal nodules of similar signal to the cortex in the T1 and the FLAIR and in the T2 weighted images. And this represents the islands of gray matter in the wall of the ventricle, together with the ischemic changes in the white matter because of the age of the patient. This is gray matter heterotopy. Next is a male child, 5 years old, presented by headache and dizziness. Yes, choroid plexus papilloma. Classic location, classic age, classic MR appearance. Uh, Surface lobulated, a strong enhancement, diffusion free, location in the site of the choroid plexus in the occipital horn of the ventricle and the age of the patient. Most of choroid plexus papillomas are seen before the age of 5 years. Next case. Yes, the answer is right. This is hemimegalencephaly on the left side. The left cerebral hemisphere is big. Its ventricle is dilated. The cortical sulci, the gyri are very thick and broad. The white matter shows abnormal signal, and all these features are diagnostic of hemimegalencephaly on the left side. Next case. Yes, and this is a Sturge-Weber disease. You see the enhancement on the leptomeninges because of the angioma on the surface of the brain, and is characteristically located in the temporo-occipital area, but can extend to the frontal and parietal regions, and sometimes can be bilateral. One of the criteria well known for this disease is homogeneous enhancement and enlargement of the choroid plexus on the site of the lesion, on the side of the lesion because of the hypervascularity going to the choroid plexus. And recently it was reported that even the opposite choroid plexus can also show hyper enhancement and increase in its volume. This is Sturge-Weber disease or leptomeningeal angiomatosis. X-ray of the abdomen of an infant. Yes. Necrotizing enterocolitis is the right answer, and this is not pneumatosis intestinalis in adults, but necrotizing enterocolitis in the pediatric age group, especially in premature infants. And you got air in the wall of the small bowel, and you got air in the portal venous tract, and this is reversible and is not incompatible with life. But in adults, if you see air in the portal venous system, this means that the bowel is ischemic and gangrenous, and this is the pre-mortem phase. A chest X-ray of a newborn with excessive drooling, and OA meaning esophageal atresia. Okay, yes, and this is esophageal atresia. And then the next question, with tracheobronchial fistula or without? Without, yes, because of absence of air in the abdomen, gasless abdomen, and the nasogastric tube coiled and go back into the esophagus means that there is esophageal atresia, and the distal segment of the esophagus is not connected to the airways, then you do not see air in the abdomen, and this is esophageal atresia without tracheoesophageal fistula. It is easily diagnosed only by introducing the nasogastric tube or the ryle tube, and sometimes they inject barium or gastrographene to look for the site of occlusion. Next case is a plain film and barium meal of an infant with vomiting also, duodenal atresia. Yes, and this is what we call double bubble duodenal atresia. The first bubble is in the stomach, and the second bubble is in the proximal part of the duodenum. And this is characteristic of the duodenal atresia, whether from the plain film or from the barium study. Next case, plain film and barium enema. Yes, meconium ileus, right answer. Yeah, you can easily appreciate the pellets of inspeciated meconium in the distal part of the ileum as well as in the ascending colon, which is very characteristic of meconium ileus. Next case, barium enema. Yes, right. The answer is right. Hirschsprung disease with a ganglionic segment involving part of the sigmoid colon and part of the descending colon with huge dilatation of the colon proximal to the affected segment. This is classic appearance of Hirschsprung disease. CT of the abdomen. Hydatid cyst. Yes, the answer is right. You got this hydatid cyst, which is actually arising from the left lobe of the liver, projecting outside the liver. It shows the very classic appearance of hydatid, of a big cyst with multiple daughter cysts arranged on the inner wall of the big cyst, together with some linear calcification of its wall, diagnostic of hydatid cyst. هذا وبالله